pulse oximeter shines red and infrared light through tissue and measures the absorption ratio of oxygenated and deoxygenated hemoglobin. When these devices were calibrated predominantly on lighter-skinned populations, melanin, which absorbs light across those same wavelengths, introduced a systematic measurement error. The device reports 93% oxygen saturation, while the patient's true arterial saturation has fallen to 88. Researchers call this occult hypoxemia. Black patients are nearly 3 times more likely to experience it. Every AI triage system that ingests pulse oximetry as a core feature inherits that hardware error. Every model trained on billing codes inherits the documentation gaps of historically biased clinical practice. The problem is not the inference engine. It is the assumption that a generalist language model applied over a biased data stream can deliver equitable clinical decisions. This paper argues that correcting it requires an architectural shift from probabilistic wrapper to fairness-aware deep AI. The Epic Sepsis Model makes the case. Developer internal validation claimed an area under the curve of 0.76 to 0.83. Independent external validation at Michigan Medicine returned 0.63. Sensitivity, 33%, 2 in every 3 sepsis cases missed. Positive predictive value, 12%, 88 of every 100 alerts, false alarms. The failure runs deeper than overfitting. Sepsis models are trained on clinical labels derived from billing codes that are themselves the product of biased clinical judgment. If clinicians historically order blood cultures later in black patients, the model learns to associate sepsis with the physiological signatures of white patients. The AI misses the patient because the historical labels were biased, and the clinician misses the patient because the alert never fired. The paper describes a 4-layer architecture designed to interrupt that bias loop at every stage. Layer 1, representation alignment. An adversarial debiasing network runs alongside the primary clinical model. An auxiliary predictor attempts to infer race and protected demographic attributes directly from the primary model's internal feature representations. Whenever the adversary succeeds, the primary model incurs a training penalty. The optimization pressure forces the model to discard demographic signals while preserving clinically relevant pathophysiology. It becomes sightful to disease and blind to race. Layer 2, domain-specific fine-tuning. Generalist weights give way to expert-adjudicated clinical ground truth, not billing codes, not EHR extraction, but labels derived from peer-reviewed adjudication. For maternal health, this means training on the California Maternal Data Center's obstetric comorbidity scoring system, which adjusts for chronic hypertension, gestational diabetes, and the comorbidity patterns specific to underrepresented populations. Layer 3, multimodal signal fusion. The pulse oximetry problem cannot be corrected at the sensor. Downstream, the architecture applies temporal regression of nonlinear dynamics, fusing oximetry with heart rate variability and lactate trends across time. If lactate rises while the pulse oximeter holds stable, the system flags a signal discrepancy and prompts an arterial blood gas confirmation, the gold standard that the oximeter cannot replicate. Layer 4, external validation. Before deployment at any institution, the Population Stability Index measures the divergence between the local patient population and the training cohort. A high index score mandates recalibration before the first clinical recommendation is made. The fairness objective is written into the loss function directly. L-fair equals the standard cross-entropy loss plus lambda times delta, where delta measures disparity across protected demographic subgroups. In worst group loss mode, the optimizer minimizes the maximum loss across any subgroup, accepting a modest reduction in average accuracy to eliminate catastrophic failure in the tails. The evidence is recent and specific. The Vanderbilt POST-child study found that standard pulse oximetry devices failed to detect low oxygen in 7% of pediatric patients with the darkest skin tones and 0% of those with the lightest. The error gradient tracks directly with melanin concentration. At the population level, the California Maternal Data Center found that automated early warning systems missed 40% of severe morbidity events in black patients. Once severe morbidity occurs, black women are 1.79 times more likely to die than white women. The failure is not in the incidence, it is in the rescue. The Epic Sepsis Model's 33% sensitivity and 88% false alarm rate were independently confirmed across multiple institutions. For the enterprise evaluating clinical LLMS, one study found that large language models achieved only 16.7% accuracy on dose adjustments for renal dysfunction when patient-specific variables were complex. McKinsey's analysis of the black maternal health gap found that closing it would add $24.4 billion to U.S. GDP, and save $385 million annually in preventable healthcare costs. CDC's 2023 data is unambiguous. Black women face a pregnancy-related mortality rate of 50.3 per 100,000 live births, 3.5 times higher than the 14.5 recorded for white women. That disparity persists when income is held constant. It persists when education is held constant. The CDC records that 1 in 3 black women experience mistreatment during maternity care. For the healthcare executive, the question is no longer whether to audit AI systems for demographic performance gaps. The question is who bears legal and reputational liability when a model with an 88% false alarm rate is deployed without subgroup calibration data. The position this paper takes is direct. Demand model cards with subgroup sensitivity, specificity, and positive predictive value broken out by race and age cohort. Require independent, peer-reviewed external validation, not vendor documentation. Implement worst group loss optimization. Average accuracy on a training cohort is not the metric that matters. Who the model fails and how often is the metric that matters. This brief 14 pages, approximately 18 minutes, walks through the physics of sensor bias, the mathematics of fairness-aware loss functions, and the 4-layer architecture that closes the gap between training cohort accuracy and lived patient equity. It is the technical case for equitable clinical AI. We invite the review.